Hi, I'm Chris Seigel, Professor of Urology at UCLA. Today, I'd like to speak to you a little bit about how to make a good decision if you've been diagnosed with localized prostate cancer. While you're watching this, please ask any questions you have on Twitter at the hashtag right here, UCLAMDChat, or ping us on Facebook. So today we're going to cover some of the basics of decision making in this disease, what information you might need to make a good decision, what processes and actions you should take to come to a good decision, and how to work with your doctor to get the best choice for you. We're not going to cover what particular choice you should make, because that really depends on your clinical situation and your goals, and your doctor will help you with that. But I'm hoping that after this presentation, you'll have a good chance of having a better discussion with your doctor. So, the basics of decision making. The first basic question is, who should make this decision? In older days, doctors made decisions for patients. And things have changed a little bit, and many people think that this decision is made in collaboration with the patient after hearing from the doctor. Some patients feel they're empowered enough to take on the decision themselves and make the decision on their own. We asked men at UCLA who've been treated for prostate cancer how they prefer to make decisions. What we found was that none of them felt the doctor should make the decision by themselves, although some patients, I'd say, do feel a little overwhelmed and scared and don't feel maybe they have the right tools to make the choice. And in that situation, I think you've got to get better educated, perhaps get a second opinion until you feel comfortable about participating. Most men think they should make the decision with the doctor together, or they should make the decision after hearing from their doctor. That's called shared decision making, which is a mode of decision making that's recommended for this situation by the American Urological Association, the American Cancer Society, and other professional societies that are interested in having men make good decisions about prostate cancer. In shared decision making, your doctor brings his or her clinical experience and knowledge of the literature out there about prostate cancer treatment and provides it to you in light of your own goals of care and treatment. Prostate cancer affects lots of important functions in terms of treatment, such as sexual health and urinary health. Individual patients have different goals in this area, so the doctor should really personalize the data for you. You bring your personal goals, your values, and your concerns to the table. No one else knows that better than you. And then together, you make the decision. Your doctor listens to you. He or she can interpret the evidence about what you should do in light of what your goals are, and you can come to it. He or she should make a recommendation for you. You can decide to accept that recommendation, to defer for now, if you want to think about it some more, or take a different choice. Those are all legitimate things to do because of the nature of this decision, which is kind of complicated. So how about the role of family members, friends, spouses? This is a couple's disease in many ways. If you have a significant other, because prostate cancer treatment can affect sexual health and, of course, sometimes can affect survival, your significant other might have opinions that matter in this decision. So when it's appropriate, we do like to have the spouse involved and voicing their opinions and goals too. Sometimes patients refer to the experience of family members or friends who've had cancer. And this can vary in terms of how useful it is. You may have had some information that prostate cancer is slow growing and usually is not an immediate threat to anyone's life. Other family members who've had other kinds of cancer that are more serious or faster growing may not be as relevant in terms of their experience to what's happening with you. So although that can be a very searing experience to have someone in your family have cancer, it may not be what you need to deal with. Also, patients or friends and family that have had prostate cancer may have had other types of treatments, and you may refer to them to say, how was your experience? I'd say that it's good to know, but their particular cancer and their particular situation is probably different from yours, and the right choice does depend on the person, as well as the fact that over time, treatments have changed and improved. So someone's bad experience a while back may be different from what's happening today. So not that you should not listen to their experiences, but take them in measure, considering who you are and the time difference between treatment then and now. So what kind of information do you need to make a good decision? Well, first you need clinical information about your prostate cancer and your general health. You also need information about your goals and values and preferences that are important to you. And I think you also need information about the doctor that you're seeking care from and the hospital you want to get care from. Let's go over some of that. So the clinical information that's important when considering prostate cancer treatment, there's three big things that are always important. One is, what is your PSA at diagnosis? PSA is a harmless protein made by the prostate gland. In men with prostate cancer, it's overproduced, so you have more of it in your blood. We know that the more of it you make, the bigger the chance you have of having a recurrence after treatment. So it's important to know what that level is to start. The second most important thing is your Gleason score. I'll get into this a little bit later in more detail, but Gleason score is a measure of how aggressive the prostate cancer looks on slides. And scores are typically reported as like two numbers, 3 plus 3, and sometimes as one number, and I'll go over that with you in a minute. Finally, the T stage, or the tumor stage, is also important. Because of the use of PSA testing, we're finding prostate cancer is pretty early these days. So when you examine the prostate physically, you don't feel anything abnormal. Occasionally, you're going to feel a bump on the prostate gland, and that is an indication of a higher T stage, if you can feel the tumor on rectal examination. There are some other clinical data points that different doctors might want to consider, such as how many cores of your biopsy were positive. Oftentimes between 12 and 15 cores are taken, and the proportion that are positive can be a signal of how much volume is there in terms of cancer. There's actually tests now today that some people will use to try to improve on the predictive value of PSA and Gleason score. Those are genetic tests. You might have heard of Prolaris or Oncotype DX. They're not always available, and there's some controversy about how useful they are at helping people make a good decision, but they may be useful for some people. You also need to know your own health information, what conditions you have, how they affect your overall health and chances of living beyond 10 years. So a moment to talk about the Gleason score. This can be kind of confusing for patients. These are slides taken from a prostate biopsy, and they're organized by aggressiveness. So up top here, we have the least aggressive tissue. Down here is the most aggressive tissue. The way we look at aggressiveness is to look at these little circles here are glands. The prostate makes fluid used for reproduction. So these glands make that fluid, and if the glands kind of stay looking like glands, that's not as big of a deal. And as they get more aggressive, they kind of lose their regular shape and end up looking more like sheets of tissue. That's the more aggressive type of prostate cancer. The Gleason scoring system itself has been changing. When it was initially created, Dr. Gleason said we should look at the most common pattern in the tissue and call that a grade between 1 and 5, and then look at the second most common pattern in the tissue and give that a grade from 1 to 5, and then add those numbers together for your score. So for example, if you had a pattern like that, that's a 3, a pattern like that's a 5, you would have a 3 plus 5 or an 8. One thing we noticed over the last few decades is that different pathologists would give us different gradings. So a while back, pathologists came together and began to standardize how they interpreted these slides. And as a consequence of that, we began to notice that there were fewer and fewer men with Gleason scores less than 6 that were being diagnosed. In fact, today, if someone says their biopsy somewhere else, their Gleason score was 2 plus 3, I would like to have that reviewed at UCLA to make sure that was correct. So these days, the lowest possible score you're going to see is a 6, and the highest possible score you're going to see is a 10. And there has been some ideas about changing the entire numbering system, because it doesn't make a lot of sense to have a score going from 2 to 10 when only 6 to 10 is being used. And men that have a 6 are really, they may think that 6 is in the middle of the range, but it's actually the lowest score you're going to see. So to help them with anxiety and to sort of build on knowledge we've gained over years about how aggressive prostate cancer is, the numbering system has been redone recently, and now often is reported as a group 1 to group 5. So the lowest score is 1, that's typically a man with an old score of Gleason 3 plus 3, and the highest score is group 5. So it's just a way to reassure men with lower risk cancers that it's just a score of 1. We use these data to try to predict how you're going to do after treatment. And so we take the PSA, the Gleason score, and the T stage, and put it into models to say, well, what's the chance of this prostate cancer coming back after treatment? That's what a risk score means: low risk, high risk, and medium risk. And one of the earliest ways to do this was called the D'Amico tables. Here's an example of that right here. Categorize men into low, intermediate, and high risk prostate cancers based on your PSA diagnosis. So low risk is less than 10, your Gleason score, so a 6 is low risk, and your rectal exam results, so no nodule, is good. That helps us to know how you might do after surgery. There are other ways to do this now. Memorial Sloan Kettering, the cancer hospital in New York, has an online calculator you can see here. Go online and put in your own data, and it'll give you estimates in terms of the chance of a cancer coming back after treatment. And this is either with surgery or with radiation therapy. If you use these kinds of calculators, it can be discouraging to look at sometimes if the number's not so great. I would say that don't be too discouraged, because what that's saying is that the PSA level might be measurable after treatment at some point after treatment. In many of those cases we just observe, and sometimes we give people medications to knock that down. It works for many years. So other information you'll need is your general health information. Do you have diabetes, heart disease, other serious medical problems that can shorten a person's life? That's because prostate cancer is very slow growing. And in fact, the only randomized trial we have looking at survival showed that in men who had low risk or intermediate risk disease, between surveilling the cancer and treating it, the death rates were only 1 or 2% at 10 years, and they were quite similar. So when you treat this disease, because there are side effects, you want to make sure the person has more than 10 years of life left, because otherwise you're giving them the negatives of treatment and not perhaps giving them the benefits of a longer survival. The ways that we can look at that, of course, are a bit hard to do. We can't look at a person and really very accurately say what their life expectancy is going to be. We have rough guides. Here's an example of a way to do that from the University of Michigan. They basically look at how many different conditions you have: COPD, heart failure. They number up the number of conditions you have, and based on your race, they look at the chance to live for more than 10 years. So if you're a healthy man and you have no medical problems, not until after you're 80 years old, you have less than 10 years of life left. Your doctor can work with you to further specify how you might fare in terms of overall survival. Another important bit of data you'll need is your own personal goals. This may seem kind of obvious, you know what those are, but prostate cancer affects men in ways that you don't always think about in terms of health risks. I think many people know that prostate cancer treatment can affect sexual health. That's true of both surgery and radiation therapy. And people think differently about the importance of this area. I'm always surprised sometimes older couples will come in and sexual health is still very important to them. And for some younger patients, it's not as important. So I wouldn't put a blanket recommendation on anyone about how important these things are for them. Urinary health is important. Surgery can sometimes result in a temporary leaking problem when you cough or sneeze. Radiation therapy can cause overactive bladder symptoms and running to the bathroom sometimes. Bowel health can be affected by radiation therapy, sometimes with diarrhea or bloody stools. And recovery time is important to different people. So if you're working and time off is a big deal, surgery has a 2 to 4 week recovery time. Radiation therapy is a daily visit to a hospital. And of course, surveillance can cause anxiety in some men. Some men just don't like the idea of watching something, even though they know intellectually it's not going to hurt them. There are also rare risks of all these treatments. So these are all things that someone has got to consider when making their decision, and they're kind of unfamiliar experiences for most people. One thing we have at UCLA, before patients are seen, we have them use some software that interviews them and has them make trade-offs about different outcomes that they could experience. And this is an example where you're saying, the outcome of leakage of urine, how would you trade that off against the necessity of having major abdominal surgery, and people tell us which they prefer or don't prefer. We learn more about them and give them a little report about their values before they're seen in our clinics. We also want to know information about the doctors and hospitals where they'll be getting treatment. You want to know how experienced they are in surgery, radiation therapy, and active surveillance, because there are a lot of moving parts to all of those kinds of treatments. One study has found that surgical care, at least, is centralizing to hospitals that do lots of these surgeries. And in fact, around over 100 a year is probably a minimum that a hospital should be doing to really be considered a center of excellence for prostate cancer, and probably higher than that is important. In terms of your surgeon's experience, it seems to be true that the more you do, the better you are at this. And the number cutoff tends to vary by different studies, but many people believe that at least 250 surgeries are required before a surgeon begins to really plateau in terms of minimizing complications. The complications related to hospital volume tend to be things like how often people are readmitted, perhaps the risk of blood clots in the legs, and surgical outcomes are also related to your functional outcomes, your sexual health after surgery, and also cancer-related outcomes like disease recurrences. I think it's also important to know whether your surgeon or radiation therapist in hospital have a prostate cancer program. This is an all-encompassing approach to the patient with prostate cancer that looks at not only their need for an immediate treatment, but also rehabilitation afterwards in terms of pelvic health functions like sexual health and urinary health, their psychological needs, and also the prehabilitation. Sometimes you start patients on medications even before surgery to maximize their outcomes afterwards. Some patients with higher risk prostate cancer are eligible for clinical trials, and prostate cancer programs tend to have those available, which is always nice to know in case you might need that. Lastly, I want to discuss how to work with your doctor. Remember, you have time to make this decision. Don't feel pressured. This decision, there's typically not an open and shut answer of what you should do. So I definitely think twice if someone's telling you must do something. There's one study looking at men making decisions for prostate cancer, which found that from diagnosis to up to 6 months, there was no difference in outcome based on when you had treatment. So something to consider, and of course low-risk prostate cancer is often treated with just active surveillance. So you do have time. You should discuss with your doctor how your particular clinical factors, your PSA, your Gleason score, your T-stage, and your general health, and your goals of care and your values are impacted by the evidence about how you can get to the best outcome possible. And ask for a treatment recommendation from your doctor and try to understand why they think that treatment's better than other options that are out there for you, given who you are. You should talk to your doctor about his or her personal experience with treating prostate cancer. Most of us that treat prostate cancer are used to that kind of a question. Not offended. We should be able to tell you about our experience. And also the hospital that they're going to treat you at. Ask about care after treatment. So again, sometimes we use physical therapy or other types of health professionals to help you have a better outcome after treatment, and it's important to understand what your path would be for that aftercare. And don't be afraid to get a second opinion. You do have time, and sometimes more knowledge is good. I would say probably too many opinions can also be a little overwhelming, but I think a couple opinions are a good idea. So I think there's some questions on Twitter I want to get to. Thank you. Okay, how can I educate myself online about prostate cancer? Well, there's a lot of information online about prostate cancer, and a lot of it is marketing driven, so I would be sort of aware of that. There are some, I'd say, more neutral fact-based websites, the American Cancer Society, for example, the Prostate Cancer Foundation website, the American Urological Association website. Those are all good resources to learn about prostate cancer in a low-pressure, non-marketing type environment. Are there any support groups for men who are making decisions? Yeah, this is an important point. There's a group called the California Prostate Cancer Coalition. They are kind of an umbrella organization that oversees many different support groups across the state. So it'd be easy to reach out on their website and find a group near you. It can be useful to talk to men in a setting where everyone's talking about their experience and learn more about what they've been through to help them make a better decision. Okay, that's all the questions we have for today. I want to thank you again for listening, and good luck with your treatment choice.